Now coming to bronchiectasis, it is a localized irreversible dilatation of the bronchial tree, and the involved bronchi are inflamed, easily collapsible, resulting in airflow obstruction and impaired clearance of secretion. So, the most important characteristics of bronchiectasis is irreversible dilatation, inflamed bronchi, airflow obstruction, and there is impaired clearance of secretion. It is associated with wide range of disorders, usually immunocompromised, but usually results from necrotizing bacterial infection of the lung. Surgery is required if there is hemoptysis or recurrent pneumonia. Here, this part is normal lung, and here you can see the bronchiectasis. This is normal airway and this is bronchiectasis segment, and here you can see the dilated bronchus filled with mucus, and there is scarred and thickened airway wall, and mucus is there and the airway is widened. So, dilated bronchi, scarred and inflamed myocardium, and retained secretion. Those are the hallmark of bronchiectasis. Now, coming to the pathophysiology, how bronchiectasis can happen. There is a trigger, a immunocompromise having a bacterial infection, airway inflammation is happening, and due to immunocompromise, there is ineffective pulmonary defense, and there is sputum overprotection, and the mucociliary activity is reduced, and there is impaired mucociliary clearance, excess sputum protection, and they are not able to get this sputum out of the airway. So, there is going to be lot of mucus inside the airway, and as the retained secretion has happened, more and more secretion is retained in the lung, and there is going to be lung damage, and the cycle continues. So, infection, inflammation, there is ineffective clearance, retained mucus, lung damage happens, and the cycle goes on. Now, coming to abscess. What is abscess? It is a non-anatomic area of liquefatic necrosis of the lung distal to obstruction or following pneumonia. There is liquefatic necrosis of the lung parenchyma distal to obstruction or following pneumonia. Here you can see the obstruction in the right upper lobe bronchus, and there is abscess at the right upper lobe. Here this obstruction was caused by the carcinoma of the right upper lobe. Now coming to the diagnostic feature of abscess, there are two main features. One is the thick wall of the abscess cavity, and next is going to be the air fluid level. These two things are present usually in abscess. The most important risk is soiling the healthy lung. When you reposition, the abscess pus can soil the normal healthy lung. That is very, very important. So, when you are positioning or lung isolation, you should be really careful that you do not soil the healthy lung. The optimal method of lung isolation is double lumen tube in abscess. Now, coming to the stages of lung abscess, the first stage is the inflammatory infiltrate following a lung infection. Second stage is the formation of cavity with the pus, and the third stage is obliteration of the cavity with the formation of pneumosclerosis. Now, coming to empyema, where you have collection of the pus between the visceral and the parietal pleura. This happens as a complication of pneumonia, lung infection, or surgery. Empyema complicating lung resection happens in around 2 to 16% of the patient. The incidence is quite bad. There is a 40% increase in perioperative mortality if empyema sets in. Mortality further increases when this empyema is associated with bronchopleural fistula. Here you can see the normal lung, and this is the layer between the parietal and visceral pleura, and you can see the pus being collected here. As the pus gets collected, the lung is compressed. This is a healthy lung, and here you can see the compressed lung. You can see the difference nicely. As the pus collects between the visceral and parietal pleura, the lung gets compromised. So, to compare the lung abscess and empyema, it is a rounded cavitary lesion in lung abscess, but in empyema it is lenticular or biconvex shape. The chest wall angle is acute in abscess but obtuse in emphysema. In CT, it interrupts the vascular structure in lung abscess. It causes lung compression in empyema. And there is acute angle, claw sign in abscess, but split sign, which is in which the parietal and pleura are separated and splitted. Treatment in lung abscess is antibiotics for 4 to 6 weeks. In empyema, it is percutaneous or surgical drainage. Here you can see the lung abscess, a rounded lung abscess, and here you can see the empyema, which is a collection between the visceral and parietal pleura. The abscess is like a ball in the lung. It grows circumferentially and it is round and form an acute angle when it contacts the inner chest wall. But empyema goes in the pleural space between the visceral and parietal pleura. The pleura act as an envelope, resulting in an obtuse angle where the empyema contacts the chest wall. In abscess, it is acute angle, but in empyema, it is obtuse angle.